Welcome to section 14 of metabolism. In this section, we'll be discussing lipid transport. Let's get started. This is the metabolic map provided in section 1 of metabolism. In this video, we're focusing on lipid transport. Lipid transport involves the transportation of multiple lipids, but I like to think of this as being mainly related to cholesterol metabolism. The cholesterol metabolic pathway can be seen right here. Let's zoom up on the pathway. This is a detailed figure of lipid transport, which can be found in section 14 of metabolism. This is a lot to take in, but we'll break it down step by step in this video. Hopefully by the end of the video, this figure can be used as a quick way to recall all of the information you'll need to know for your test. Let's start with cholesterol synthesis. Notice that cholesterol synthesis occurs in the liver. Acetyl-CoA is converted into HMG-CoA, which is then converted into mevalonate by the enzyme HMG-CoA reductase. This is the rate-limiting step and most important step of cholesterol synthesis. Notice that this step is inhibited by statins. Cholesterol can then be used in the synthesis of bile acids. Bile acids are secreted into the duodenum, which act as emulsification agents and facilitate the absorption of fat. Once bile acids reach the terminal ileum, which is represented right here, they can be recycled. Notice that the recycling of bile acids can be inhibited by drugs called bile acid sequestrants. A great example of a bile acid sequestrant is cholestyramine. So cholesterol can be synthesized in the liver, but also notice that it can be absorbed by the intestines when it's consumed through the diet. You can see that right here. Both cholesterol and triglycerides enter the enterocytes at the brush border of the small intestine. Notice that this step can be blocked by the drug ezetimibe. Once in the enterocytes, triglycerides and cholesterol are packaged into chylomicrons. You can see the chylomicron right here. Chylomicrons, as well as other molecules you can see on this image, such as VLDL, IDL, LDL, and HDL, are known as lipoproteins. Lipoproteins are lipid protein complexes and help carry fat throughout the blood because fat is not otherwise soluble. Notice from the figure that there is a red dot on the chylomicron right here, which represents an apolipoprotein known as ApoB48. ApoB48 is only found on chylomicrons and is necessary for chylomicron secretion from enterocytes. You can see that the key states that right here. This is an important apolipoprotein to be familiar with because it's associated with A-beta-lipoproteinemia, which we'll discuss more in a minute. I keep ApoB48 straight in my head by remembering the 8 and using the mnemonic He8 cholesterol. Because chylomicrons come from dietary cholesterol, I can remember that ApoB48 is associated with cholesterol that was eaten, hence the name He8 cholesterol. Hopefully that helps. Okay, once chylomicrons are secreted from the enterocyte, they enter the lymphatic system and then the blood. Notice that from here, HDL, which you can see right here, transfers ApoC2 and ApoE to the chylomicron. ApoC2 is a cofactor for lipoprotein lipase. As you can see from the figure, once chylomicrons with ApoC2 on their surface encounter lipoprotein lipase, fatty acids are liberated from the chylomicron. You can see the fatty acids leaving right here. It's not shown on this image, but lipoprotein lipase is present in the capillaries and it converts triglycerides into both free fatty acids and glycerol. The fatty acids can then be utilized by the tissues for energy or they can be stored for later use. As fatty acids are released from chylomicrons, chylomicron remnants are formed. You can see a chylomicron remnant right here. Notice that chylomicron remnants lack ApoC2. You can see that ApoC2 left right here. From here, the remnants can be returned to the liver by binding to the hepatic remnant receptors, which you can see right here. Notice that the third apolipoprotein present in chylomicrons is ApoE, this little green dot right here. ApoE is a ligand on the surface of chylomicrons that facilitates binding to the hepatic remnant receptors. You can see that right here. We state that ApoE facilitates binding to the hepatic remnant receptors. In other words, ApoE is necessary for chylomicron uptake by the liver. We'll talk more about this in a second, but also notice that ApoE is present on VLDL right here, ILDL, and HDL. Keeping these apolipoproteins straight can be challenging, so let's discuss a few mnemonics. First, ApoE can be remembered by thinking of E for everything. In other words, ApoE is on almost everything in this figure except for LDL. Notice that ApoE is on chylomicrons, chylomicron remnants, VLDL, IDL, and HDL. The E also helps me think of the word remnant. As we just discussed, ApoE mediates the hepatic uptake of remnant molecules. You can see the remnant receptor right here, so the E in remnant. Next, ApoC2 can be remembered by thinking of the C in ApoC2. C for cofactor. So C is a cofactor for lipoprotein lipase. Okay, let's see what your text says. Chylomicrons are produced by enterocytes and transport fatty acids and cholesterol to the tissues. B48 is necessary for chylomicron secretion from the enterocytes. ApoC2 is a cofactor for lipoprotein lipase. ApoE facilitates the binding of chylomicrons, VLDL, IDL, and HDL to the hepatic remnant receptors. Now let's focus on VLDL, or very low density lipoprotein. Notice from the figure that VLDL is synthesized in the liver right here, and it contains ApoB100 initially. You can see that right here. ApoB100 is necessary for VLDL secretion from the liver. You can see that right here. From the figure, you can see that fibrates, niacin, and fish oil all inhibit the secretion of VLDL from the liver. After secretion, notice that just like chylomicrons, VLDL picks up ApoE and ApoC2 from HDL. You can see these molecules on the HDL getting transferred to VLDL. Notice that as VLDL loses fatty acids right here, it becomes an intermediate density lipoprotein, or IDL. Also notice that at this point, VLDL lost ApoC2. That's illustrated here by the loss of this blue dot. From here, IDL is converted to LDL by the enzyme hepatic lipase. And in this process, notice that fatty acids are again released into the tissues. You can also see that ApoE was liberated in this process, which is represented by this green dot right here. Notice that LDL now only contains ApoB100. So VLDL and IDL can be converted into LDL, which can then be reabsorbed by the liver by LDL receptors. Notice these right here. But also notice that VLDL and IDL don't have to be converted into LDL, and instead can follow these blue arrows right here to the remnant pathway and be absorbed directly by hepatic remnant receptors. You can see those again right here. From the key, notice that ApoE facilitates the binding of lipoproteins to the hepatic remnant receptors. This includes VLDL and IDL. On the other hand, ApoB100 facilitates hepatic uptake of LDL by the LDL receptor. So facilitates binding of LDL to the hepatic LDL receptor. We've shown that right here. Okay, let's see what your text says. VLDL is produced by the liver and transports fatty acids and cholesterol to the tissues. As VLDL loses fatty acids, it becomes IDL. ApoB100 is necessary for two things. First, the hepatic secretion of VLDL, and it also facilitates the binding of LDL to the hepatic LDL receptors. ApoC2 is a cofactor for lipoprotein lipase, and ApoE facilitates the binding of chylomicrons, VLDL, IDL, and HDL to the hepatic remnant receptors. This is a table from section 14 of Metabolism and provides a nice summary of the lipid disorders. Let's discuss A-beta lipoproteinemia first. A-beta lipoproteinemia, which you can see right here, is caused by mutations in a microsomal transfer protein. This protein is responsible for the synthesis of apolipoprotein B. In other words, this disorder results in an absence of ApoB100 and ApoB48. From the table, notice that a lack of ApoB100 results in an inability to secrete VLDL from the liver. As a result, these patients have decreased VLDL and the remnants of VLDL, including IDL and LDL. Also notice that ApoB48 is necessary for chylomicron secretion from the enterocytes, like we've discussed. As a result, lipids cannot be absorbed properly, and they accumulate throughout the gut, resulting in steatorrhea. Impaired lipid absorption also means that the absorption of fat-soluble vitamins is affected. So these patients can develop a fat-soluble vitamin deficiency. Of the fat-soluble vitamins, vitamin A is probably the most important to remember for this disorder. Impaired metabolism of vitamin A results in vision problems, including degeneration of the retina. Also, because lipids cannot be absorbed properly, the red blood cells lack lipids in the cell membrane, resulting in a disorder known as acanthocytosis. From this figure, you can see the spiny projections from red blood cells right here. These red blood cells are called acanthocytes, or spur cells. Okay, let's do a question. A 16-year-old female is brought to the physician by her father due to worsening vision over the past 2 weeks. He states that she has a history of mild cognitive impairment and diarrhea. Fundoscopy reveals bilateral retinitis pigmentosa. Laboratory findings are significant for low levels of total serum cholesterol. What apolipoproteins are most likely deficient in this patient? From the question stem, hopefully you notice that this patient has worsening vision, bilateral retinitis pigmentosa, and low levels of total serum cholesterol. These findings are consistent with A-beta lipoproteinemia. As we just discussed, this results in a deficiency of ApoB48 and ApoB100. From the table, we can see that this results in decreased chylomicrons, VLDL, IDL, and LDL, which explains why she had low levels of cholesterol. The vision changes can be explained by vitamin A deficiency, so a fat-soluble vitamin deficiency. The neurological changes can be explained in part by the vitamin E deficiency. The diarrhea can be explained by fat accumulation in the bowel, which acts as an osmotic agent and can result in lifelong steatorrhea. So again, this patient most likely has a deficiency of ApoB100 and ApoB48. Okay, let's continue discussing lipid transport and then we'll return to this table. As I showed a few slides ago, hepatic lipase, right here, is responsible for converting IDL to LDL. Notice that during the conversion of IDL to LDL, ApoE was lost. So again, this means that LDL only contains ApoB100, which we can see right here. And ApoB100 is a ligand that interacts with the hepatic LDL receptors, which is responsible for the uptake of LDL by the liver. You can see these receptors right here. We can also see in the key that ApoB100 facilitates the binding of LDL to hepatic LDL receptors. LDL is unique because it delivers a lot of cholesterol to the tissues. Based off of this information, it should make sense why LDL is often referred to as the bad cholesterol. It's bad because it delivers cholesterol to the tissues. On the other hand, high-density lipoprotein, or HDL, right here, is considered the good cholesterol because it acts like a sponge and removes cholesterol from the tissues. Okay, before we discuss HDL, notice that PCSK9 inhibitors, right here, work by inactivating LDL receptor degradation. In other words, there are more LDL receptors present at any given time, so the amount of LDL removed from the bloodstream increases. This effectively decreases LDL and can be helpful in treating patients with dyslipidemias. Okay, now let's talk about HDL. Notice from the image that HDL is released from the liver and soaks up cholesterol, which you can see right here, kind of like a sponge. The enzyme that catalyzes this step is called lecithin cholesterol acyltransferase, or LCAT. You can see LCAT right here. There's a lipoprotein called apolipoprotein A1, which activates LCAT. However, I haven't included it in the overview figure because it's not as clinically applicable, so it's rarely tested. Notice that the HDL molecule right here now contains a little C with a circle in it. This represents the cholesterol that it's absorbed. From here, the HDL can either transfer this cholesterol to another lipoprotein, such as VLDL, which you can see right here, or it can return the cholesterol to the liver via HDL receptors, which you can see right here. Notice that HDL contains ApoE. You can see that on HDL right here, and right here. And ApoE facilitates the hepatic uptake of HDL. If we follow HDL towards the bottom of the figure, notice that the C on the HDL was transferred to the VLDL. You can see it right here now. Also notice that this step was catalyzed by the enzyme cholesterol ester transfer protein, or CETP. For the sake of simplicity, only VLDL was shown in this figure, but in reality, HDL can deliver cholesterol to other lipoproteins, such as LDL. Before we discuss some of the other lipid disorders, we should briefly review how cholesterol is measured. When a physician orders a lipid panel to measure the total cholesterol, they're really looking at LDL, HDL, and VLDL. VLDL transports a high concentration of triglycerides compared to other lipoproteins. So the VLDL component of a lipid panel is used as a surrogate to measure triglycerides. Chylomicrons also carry a lot of triglycerides, but this comes from the diet. This is why if a patient gets a lipid panel when they're not fasting, it can falsely elevate the triglyceride component of the test. Okay, with this in mind, let's return to the dyslipidemia table. Notice from the table that type 1 dyslipidemia, or familial hyperchylomicronemia right here, is caused by a defect in ApoC2, which is a cofactor for LPL. It can also be caused by a defect in LPL itself. Either of these defects results in the same outcome. VLDL and chylomicrons are unable to be properly metabolized, resulting in elevations of both chylomicrons and VLDL. As we just discussed, because VLDL is a surrogate for measuring triglycerides, the triglyceride levels will be elevated in a lipid panel. Okay, before we discuss the symptoms of these disorders, you should know that these really are not as important as the other information in the table. In questions for step 1, you'll usually be given some of the symptoms along with some additional key information about a lab finding or a protein defect. This other information in the question stem is critical and is ultimately what will help you get the question right. Because many of the symptoms overlap, I highly recommend that you recognize xanthomas, pancreatitis, and coronary disease as symptoms of a dyslipidemia, but not specifically which symptom correlates with what type of dyslipidemia. The one exception to this rule is A-beta lipoproteinemia, and this is because of the unique symptoms that it has. We've already discussed that disorder. So let's move on. In type 1 dyslipidemia, patients can have xanthomas. These are caused by lipid-laden macrophages, so it should make sense that all of these disorders can result in xanthomas. Recall from pathology that one of the causes of pancreatitis is elevated triglycerides, so it shouldn't be a surprise that type 1 dyslipidemia, which has very high triglycerides, can cause pancreatitis. From the figure, notice that ApoC2 is a cofactor for lipoprotein lipase. In type 1 dyslipidemia, ApoC2 is absent, or lipoprotein lipase itself is defective. Both of these abnormalities result in the same outcome. VLDL and chylomicrons are elevated. Notice that both VLDL and chylomicrons contain ApoC2. You can see that right here. Now let's discuss type 2 dyslipidemia. Notice that this is caused by a defect in ApoB100, or the LDL receptor. From the figure, you can see that ApoB100 is present on VLDL right here, as well as the remnants of VLDL, including IDL and LDL. This protein is a ligand that allows the lipoproteins to bind to the LDL receptor right here. In type 2 dyslipidemia, the ApoB100 protein is defective. Unlike A-beta lipoproteinemia, this type of mutation allows VLDL to be secreted from the liver. So VLDL can still be secreted from the liver. However, this particular disorder prevents LDL from being endocytosed by the liver at the LDL receptor. From the figure, notice that lipoprotein lipase and hepatic lipase still function. This means that much of the VLDL and IDL are converted into LDL. Also, VLDL and IDL combine to the remnant receptors right here on the liver, which allows them to be removed from the circulation, while LDL is unable to do so because it relies exclusively on the LDL receptor. This means that VLDL and IDL levels are relatively normal, while LDL levels are high. From the table, notice that LDL is the only lipoprotein that's elevated. This is because it's unable to be endocytosed by the liver. Because LDL is the bad cholesterol that delivers cholesterol to the tissues, it should be no surprise that this disorder increases the risk of coronary disease. Okay, now let's discuss type 3 dyslipidemia, or familial dysbeta-lipoproteinemia. In type 3 dyslipidemia, there is a defect in ApoE3 and ApoE4. For simplicity, this image only shows ApoE rather than ApoE3 and ApoE4, which are present on chylomicrons, chylomicron remnants, VLDL, and IDL. This protein is a ligand that allows the lipoproteins to bind to the remnant hepatic receptors, thus facilitating endocytosis by the liver. In type 3 dyslipidemia, the ApoE3 and ApoE4 lipoproteins are defective, which means VLDL, IDL, chylomicrons, and chylomicron remnants are unable to be endocytosed by the liver using the remnant receptors. This means that all of these lipoproteins are elevated. Just like in type 2 dyslipidemia, some of the VLDL and IDL particles are converted into LDL, which can then be returned to the liver. However, the defect in the remnant reabsorption, right here, results in an overall reduced ability to clear VLDL and IDL. So VLDL and IDL levels are high. From the table, notice that ApoE3 and ApoE4 particles are defective. These particles allow chylomicrons and chylomicron remnants to bind to the hepatic receptors. I've only shown chylomicrons in this table for simplicity, but chylomicrons and chylomicron remnants are unable to be properly absorbed. Also notice that VLDL and IDL are unable to bind to the hepatic lipoprotein receptors. Because these lipoproteins cannot be endocytosed by the liver, they're elevated. Notice that collectively this results in high triglycerides. We can see that the symptoms of this disorder include xanthomas and coronary disease. However, for whatever reason, these patients actually do not usually have pancreatitis, despite their high triglyceride levels. This is not very well understood. But again, remember that the symptoms of the disorders are not as important as knowing the lab findings or the protein defects. The symptoms will just give you clues as to what disorder you should think about. Type 4 dyslipidemia, or familial hypertriglyceridemia, has multiple protein defects, but ultimately results in the overproduction of VLDL. Because VLDL is a surrogate for triglycerides, we can expect triglyceride levels to be elevated. As with most other disorders, elevated triglyceride levels is a risk factor for pancreatitis, so these patients can develop pancreatitis. Okay, let's do another question. A 24-year-old male presents for a routine visit. On exam, he is noted to have yellow nodules on the flexor tendons of his hands and feet. His total serum cholesterol and LDL are elevated. His triglyceride levels are normal. What apolipoprotein is most likely defective in this patient? Hopefully from the question stem, you notice that this patient has xanthomas, which we can deduce based on the yellow nodules on the flexor tendons of his hands and feet. He also has elevated LDL and normal triglycerides. The xanthomas should immediately make you think of a dyslipidemia. The elevated LDL and normal triglycerides should make you think of type 2 dyslipidemia. If we look at the table, we can see that type 2 dyslipidemia is the only dyslipidemia that results in elevated LDL. Also notice from the table that this is caused by a defect in ApoB100 or the LDL receptor, which are both responsible for the hepatic uptake of LDL. From the overview figure, we can see that a defect in the LDL receptor, right here, or ApoB100 would both result in increased levels of LDL. So in answer to the question, ApoB100 is most likely defective. Okay, let's do another question. A 65-year-old male presents to the ED with sudden onset left-sided weakness. He has a facial droop and slurred speech. He is started on several medications, including atorvastatin. How will this drug likely alter the number of LDL receptors on hepatocytes? From the question stem, hopefully you notice that this patient had a stroke and was started on a statin drug, atorvastatin. From the overview figure, notice that statins inhibit HMG-CoA reductase, which decreases the synthesis of cholesterol. Because the liver has less cholesterol than normal, it increases the expression of the LDL receptors in an attempt to restore hepatic cholesterol levels back to normal. So increased LDL receptors. This reduces the concentration of circulating LDL, which is why it can be useful in patients who have cardiovascular or cerebrovascular disease. So in answer to the question, the number of LDL receptors on hepatocytes will most likely increase in this patient.